Yogah Karmasu Kaushalam.
Good afternoon, everyone. Today the topic is advances in assisted reproductive technologies. But before we go to the advances, I'd like to refresh our memories a little bit about the basics in vitro fertilization. We all are well aware that normal fertilization takes place in the fallopian tubes after an ovum has been ovulated, and the early steps of embryonic development are also passed in the fallopian tube before the blastocyst is implanted in the uterus. This normal process has been translated in the laboratory in vitro conditions, where the ovum is collected from the ovary, cultured in the laboratory. The spermatozoa are simultaneously cultured and washed, prepared, and then fertilization occurs in the laboratory in sterile conditions in a culture medium. The early stages of embryonic development also occur in the laboratory in a culture medium. They are followed microscopically, and then at a certain time when the embryo is around an 8-cell stage, a day 5 embryo is transferred via a sterile catheter by a gynecologist, a surgeon, into the fundal end of the uterus for the purpose of implantation. This process was developed as early as 1976 by Steptoe, Edwards and Bavister, and the little baby that was born, Louisa Brown, was was recorded as the world's first test tube baby. These scientists and physicians were awarded the Nobel Prize in Physiology and Medicine in 2010 for this discovery. Here is the picture of Patrick Steptoe and Bob Edwards with the world's first test tube baby. And here is the girl, the same little child, with the desiccator or the sterile conditions in which she was conceived. And today she has her own normal conception, normal fertilization, normal pregnancy, which is proof that in vitro fertilization babies are totally normal. India had its first test tube baby with Dr. Indira Hinduja at the helm at KEM Hospital, Mumbai. And throughout the country, various laboratories established in vitro fertilization, expertise developed, training programs were conducted, and today its state-of-the-art technology is seen all over the country. When will a doctor advise a patient to go for an IVF? Generally, when there is something wrong with the fallopian tube in the female, either there is an infection, an adhesion, a block, or there is a history of fibroids, uterine fibroids, failure of ovulation, failure of the ovary to release the ovum, or in conditions of many cysts in the ovary, polycystic ovarian syndrome, or in the case where the male has a low sperm count, abnormal sperm morphology, low motility, or there are several cases where the condition cannot be identified, the cause for infertility cannot be identified, and hence the doctors will advise the patients to go for an in vitro fertilization. As we have seen, it involves the fertilization under laboratory conditions, which is then transformed into an embryo and then implanted into a receptive uterus. But for all this to take place, the female has to be primed. She has to be treated with hormones so that the ovary develops more number of follicles. When in vitro fertilization is being carried out under artificial laboratory conditions, the doctors have to fertilize at least 6 or 8 spermatozoa ovum by the spermatozoa in vitro, so that the chances of success of implantation increase. So to get more number of ovum, the female has to be initially her own hormonal secretions have to be downregulated so that she can respond to the injected hormones to bring her to a condition where the ovaries can respond to the hormonal stimulus and produce more number of follicles. So hyperstimulation of the ovary is carried out by injecting artificial hormones like clomiphene citrate or recombinant hormones made by recombinant DNA technology such as recombinant FSH, followed by monitoring the development of the follicles in the ovary, monitoring the estradiol levels, the human chorionic gonadotropic levels, and the ultrasound scanning to see the development of follicles in the ovary. After the clinician and the embryo technologist confirm that there are sufficient number of follicles, an injection of HCG or LH is given and ovulation occurs 36 hours later. The whole laboratory and the surgical setup gets ready to collect the ovum, which is the recovery of the oocyte, collecting the oocyte, done by aspiration under sterile conditions, under surgical conditions, through a transvaginal approach. So the catheter is passed through the wall of the vagina and collecting along with the ovarian fluid, collecting as many ovum as possible and that have been ovulated. And this is then placed in the culture medium and checked microscopically in the laboratory for the oocyte morphology and the presence of cells around the oocyte. So in order to know that the oocyte is ready for fertilization, the embryo technologist checks the cumulus oophorus around the oocyte, checks the nature of the cytoplasm, whether it is granular enough, whether the oocyte is mature enough. Presence of the first polar body indicates that a certain stage of cell division has occurred. The size of the ovum also reflects its maturity status, and then it is incubated until the laboratory is ready to carry out the in vitro fertilization. At the same time, the semen sample is collected in the andrology laboratory from the male partner, and it is checked for the number of spermatozoa, the shape and morphology of the spermatozoa, and the forward progressive motility. After it is assessed for whether there are bacterial cells or any other interfering cells in the sample, it is then processed by a preparation technique using a density gradient medium. And in this technique, a motile, viable, very good quality fraction of spermatozoa are separated, and this is what is used for the in vitro fertilization. But this fraction of spermatozoa is not yet ready to undergo the acrosome reaction and release the enzymes necessary for penetrating the ovum. So for that purpose, it is also capacitated using a calcium ionophore solution, and that causes it to become extremely motile. The outer acrosomal cap ruptures and the necessary enzymes are released to scatter this covering of cells around the ovum. That is the zona pellucida, the cumulus oophorus, the cumulus cells, the zona cells. They are scattered and the spermatozoa undergo the final phase for penetration of the vitelline membrane and carry out the fertilization. So the spermatozoa are added to the ova in the culture medium. It's covered by a small drop of oil, and the embryonic development is followed microscopically using phase contrast, time-lapse imaging, so that the embryo technologist can see at what stage the embryo has reached. The presence of two pronuclei, the male and the female pronuclei, indicate that positive fertilization has taken place. So the doctor confirms that fertilization has occurred successfully in vitro, and then the embryo is cultured under laboratory conditions. the first cleavage stage, the 4-cell stage, the 8-cell stage, until day 5 when the blastocyst is formed. Now, day 5 is a crucial day because this is the time when hatching occurs. The blastocyst, which is to be implanted, will be, the outer covering is broken and the blastocyst is released for implantation. So at this stage, the clinician, the gynecologist, will implant the blastocyst into the receptive uterus. Receptive uterus means, again, the female has to be injected with the necessary hormones to prime that uterus, to make that uterus ready, expansion of the endometrium, expansion of the muscular layers, to make the endometrium ready to receive this little embryo for a purpose of implantation. Sometimes, if 4 to 5 or more ovum have been fertilized and there are at least 5 or 6 some extra embryos, then the extra embryos are cryopreserved in liquid nitrogen. And in case the first attempt fails, then repeated cycles are possible because you need not disturb the patient again by collecting an ovary, priming the ovum, priming the ovary and collecting the ovum. Instead, you can just freeze the embryo and collect it later for a second attempt. So once the embryos are checked microscopically and they have reached the correct stage, they are again transferred, embryo transfer takes place into the receptive uterus where the female has been injected and primed to receive the fertilized blastocyst. The catheter is introduced via the cervix and it is then checked after releasing the embryos. It is checked thoroughly that the embryos are properly released into the ovum. Despite all the care, all the patience, all the minute details that both embryo technologist and the gynecologist go through, there are many risks and there are many failures. One of the risks of IVF is that the female may suffer from ovarian hyperstimulation syndrome due to the repeated injection of hormones. This results in swelling of the ovaries, accumulation of fluid in the abdomen, abdominal pain. It could even mean headaches, depression, stress, anxiety. So the ovarian hyperstimulation syndrome is one of the few risks associated with in vitro fertilization. Because more number of ova are collected and they are fertilized, and more number of embryos are sometimes transferred to increase the success of implantation or the probability of implantation, there's a possibility of twinning, having more than one implantation. So twins or triplets or quadruplets may also be an outcome of IVF. Sometimes the embryo does not respond properly even after an implantation, and there could be an abortion. Risk of abortion is also seen after an in vitro fertilization. And because most of the gametes are collected, handled in vitro, the in vitro conditions may not be conducive for the development of the embryo. Congenital abnormalities are also a risk faced as a side effect of in vitro fertilization. Although the current data suggests that the success of in vitro fertilization is 50 to 70%, nevertheless, there is a 30% failure rate. And very often, in the first trial or the second trial, success of in vitro fertilization, conception, implantation is low. The causes are many. It could be due to a faulty culture system. Suddenly, in vitro, the embryo fails to go beyond the 4-cell stage. It reaches a 5-cell stage and then stops. It doesn't go from 4 to 8-cell stage. Failure of cleavage. The gametes may have some abnormalities initially itself, and therefore in vitro fertilization does not take place. Or the spermatozoa may have some anomaly and fail to penetrate the vitelline membrane of the ovum. Or there are several other factors that could lead to impaired in vitro fertilization. So because of this low success rate and possible failure, scientists, doctors, clinicians made certain modifications in the technology. So where they found that very often the fertilization fails in vitro, instead of implanting the embryo at the 5 cell stage, at the 8th cell stage, day 5, the gametes are collected, the gametes are cultured, checked for maturity. The spermatozoa are prepared for a good quality fraction, and the gametes are transferred into the fallopian tube of the female. Instead of an embryo being transferred into the uterus, the gametes itself are transferred into the fallopian tube so that fertilization can occur in the natural milieu, in the natural microenvironment, may be more beneficial for the purpose of developing the early embryo. So this procedure is called gamete intrafallopian tube transfer, or GIFT. It's one of the first assisted reproductive technologies modified from the original in vitro fertilization. Very often, if fertilization does occur in vitro, but the early embryonic stages are arrested, division is arrested in vitro. So they, instead of allowing those day 5 embryonic stages to occur in the laboratory, the zygote itself, soon after fertilization, the single cell zygote is transferred into the fallopian tube, and the early embryo is given the natural environment to proceed for its normal division stages, cleavage, early cleavage. So this is called zygote intrafallopian tube transfer, and this also proves to be a little more beneficial than GIFT or simple IVF. Very often they take the pronuclear stage itself. As soon as the 2 nuclei are seen under the microscope, even before a complete zygote is formed, an early pronuclei stage is transferred into the fallopian tube so that we give the embryo minimum exposure to artificial laboratory culture medium and laboratory conditions. Yet again, with all these modifications in assisted reproductive technology, there are failures. Very often, fertilization does not take place, conception does not take place. So again, scientists the world over and doctors, clinicians came together and they used what is known as micromanipulation. Micromanipulation uses an inverted microscope fitted with a micromanipulator apparatus so that there can be a little more interaction with the gametes to actually help the spermatozoa to cross the final barriers of the cumulus oophorus, zona pellucida, cross the white line membrane, and ensure that a positive fertilization takes place. So a little more manipulation can be done using the micromanipulator. So this is an inverted microscope with a temperature controlled stage. And to the stage is fitted what is known as the micromanipulator apparatus. It comprises of a holding pipette. The holding pipette is made of borosilicate glass with a very fine internal diameter. And it is connected to a pressure controlled pump where a small negative pressure of 1 atmospheric pressure can be created. Such a pressure our own hands, the human hand cannot exert. So it's an automated pressure controlled micropipette. It creates a small negative suction force just below the ovum so that the ovum is held in position in the petri dish in the culture medium. On the other side is the injection pipette. So this micro injector needle is also made of borosilicate glass drawn out to a very, very fine internal diameter. And this is also connected to a pressure controlled pump where under controlled pressure, something can be injected, the sperm sample culture medium, something can be injected into this culture system without much force. If we were to do it with the human hand, we would be injecting with a lot of force, which would damage the gametes or make the gametes flow away. But this is pressure controlled micro injection. And both the pipette and the injector needle can be controlled with a vernier scale movement, which is automated. The entire apparatus is fitted with the photography, videography, which can control time-lapse photography, phase contrast photography, etc. And there's a dual monitor system. So it has a dual monitor system. It has a pressure-controlled pump, which controls the holding pipette and the injector needle. And this is an inverted microscope. And it helps to carry out the micromanipulations necessary to help the spermatozoa carry out a positive fertilization. So this is a very highly magnified view of the micromanipulation process. This is the holding pipette, okay? And a small negative force is created so that this ovum can be held in position, adhere to the glass surface of the petri dish in the culture medium. And this is the borosilicate glass microinjector needle drawn out to a very sharp edge, and it can help in introducing the spermatozoa at various regions so that the spermatozoa is aided in the process of fertilization. So micromanipulation involves great training, great expertise, but it has increased the success of fertilization several-fold. The earliest process and use of micromanipulation was seen in the process of assisted hatching. We have seen earlier that at day 5, this outer covering has to be broken so that the blastocyst is ready to exit for implantation. Very often in some patients, this outer layer fails to break, fails to hatch. Hatching, this process is called hatching, and hatching does not take place. So the blastocyst remains confined and cannot implant. Micromanipulation has provided a means whereby with the holding pipette, this embryo is held in place, and with the help of the needle, this outer covering is broken, is removed. And therefore, the blastocyst is assisted in coming out of this shell. Assisted hatching helps the blastocyst for the purpose of implantation. The ovum is protected by several layers, the outermost layer being the cumulus oophorus, and below that is this layer shown in blue, which is the zona pellucida. The spermatozoa has to penetrate through the zona if it has to reach the vitelline membrane. And that is where fertilization fails very often. The spermatozoa are unable to cross the zona. With the help of the micromanipulator, zona drilling is carried out. An acid tyrrhode solution is released, and that scatters the zona, and the microinjector needle then helps to dissolve or dissect out the zona cells, the zona layer, and with the help of the injector needle, spermatozoa are introduced very close to the vitelline membrane. So this barrier of cumulus and zona pellucida is then crossed with the help of micromanipulation. This was followed by a technique given by Palmero called subzonal sperm insemination. If the spermatozoa cannot undergo the acrosome reaction, and if the spermatozoa by themselves cannot pass through the cumulus oophorus and the zona pellucida to reach the vitelline membrane, a few spermatozoa are transported via the injector needle. This is the holding pipette which holds the ovum in place, and the injector needle carries a few spermatozoa. The injector needle passes through the cumulus, through the zona, and places the spermatozoa just outside the vitelline membrane. Now, this was introduced at a time when it was thought that we should not damage the gametes, we should not touch the gamete, we should not penetrate the gamete. So the spermatozoa has to do the final penetration across the vitelline membrane by itself. While Susie did add a little bit of success to in vitro fertilization, still many spermatozoa, even after Susie, could not cross the vitelline membrane. And therefore, Palmero gave the technique of intracytoplasmic sperm injection, or ICSI. The microinjector needle then holds a single spermatozoa, a modified single spermatozoa, And that injector needle passes through the cumulus, through the zona, across the vitelline membrane, and transfers the single sperm into the ooplasm. All this while, the ovum is held in position with the micropipette, and the polar body is kept in a certain direction in a 6 o'clock position, and the injector needle therefore injects a single sperm into the ooplasm, into the cytoplasm of the ovum. So if we compare the micromanipulation techniques in SUSY, several spermatozoa are placed just outside the vitelline membrane. In partial zona dissection, only the zona is broken so that the sperm themselves have to pass through this region. But in ICSI, a single sperm is actually transported across the vitelline membrane and injected, released into the ooplasm, ensuring that at least a positive fertilization could take place. The coming of ICSI, the coming of intracytoplasmic sperm insemination, enhanced the technique of in vitro fertilization, and success rates escalated to a very high degree. So the single spermatozoa passing through the layers, through the barriers, through the vitelline membrane, and injected into the ooplasm of the ovum. This gave a very big boost to the technique of in vitro fertilization and made at least fertilization positive. Now, sometimes, despite injecting that spermatozoa, the single modified spermatozoa, into the ooplasm, it's possible that further cell division does not take place, the zygote is not formed. So it could be that this selected spermatozoa is not morphologically normal. Therefore, ICSI was clubbed with a technique called intracytoplasmic morphologically selected sperm injection. This is a technique where, using high magnification digital imaging, they examine the spermatozoa. They exclude spermatozoas even after sperm preparation. Spermatozoa with deformities and suspected abnormalities are excluded. All abnormally shaped spermatozoa are excluded, and only very, very good quality spermatozoa are selected for the final IMSI process. In this process, because they are injecting the single spermatozoa, the midpiece and the tail have to be surgically removed, have to be with the help of the needle, micromanipulator needle, so that mitochondria in the midpiece of the sperm are not injected into the ooplasm. Mitochondria comes only from the mother. The sperm genome in the head region of the sperm is the only part of the spermatozoa that should be injected through the IMSI process. Now, this is all possible. All these micromanipulation techniques are possible when the male is able to release the sample, or a donor is able to give the sample. Very often, the male partner suffers from conditions in which production of the spermatozoa is not possible. Okay, it could be impotence, it could be ejaculatory failure, it could be several conditions, neurological conditions, that the sperm sample, the semen sample, is not produced by the male partner. There are now micro techniques, microsurgical techniques, where the surgeon can collect the sperm sample, the gynecologist can collect the sperm sample directly from the organs, the epididymis or the testes. This is called percutaneous epididymal sperm aspiration, or PESA, where microinjector needle is introduced into the tubules of the epididymis around the testes, and from here, mature spermatozoa are collected and taken for the purpose of in vitro fertilization. Or testicular sperm aspiration, where from the seminiferous tubules of the testes, from within the tubules, a sample of spermatozoa are collected by microsurgery and taken for the in vitro fertilization process. Or testicular sperm extraction, small biopsy is taken, and from the biopsy, a very good fraction of good quality spermatozoa are prepared and taken for the purpose of in vitro fertilization. So in cases where the male partner is not able to produce the sample, then it is collected through micro techniques where the epididymal spermatozoa or the testicular spermatozoa are selected and taken and then selected for the purpose of in vitro fertilization. Despite all these modifications, the research is still underway to improve the technology and still lower the failure rate, still make it easier for the patients. Because a single spermatozoa is injected in the process of ICSI, does it mean that it will always be successful? No. Even ICSI has its failure rates. Even ICSI has certain repercussions. The single sperm genome could be faulty. There could be small changes in the sperm morphology that due to manipulation, etc., which could even lead to failure of fertilization further or embryonic cell division. So it's necessary, therefore, before implanting that embryo, to check that embryo and find out if there is any problem or any mutation, any anomaly associated with the DNA of the embryo. And pre-implantation genetic screening is carried out, or pre-implantation genetic diagnosis is carried out. And this helps the clinician and the embryo technologists, along with their microscopic data, to understand whether that is a good quality, healthy embryo with normal DNA and no mutations. So pre-implantation genetic diagnosis is carried out when there is a definite known genetic disorder. The patient, the female or the male, has some disorder which runs in the family. Could be sickle cell anemia, could be Huntington's, could be thalassemia. There is a known genetic disorder and a high risk of that patient to deliver an embryo, to have an embryo carrying that mutation. And probably she has had a history of that, of an embryo or a child with that disorder earlier. So when we are checking for just one disorder, when we use the genetic analysis to check for one known genetic anomaly because of a history in the family, it is called pre-implantation genetic diagnosis. But when you screen just to see that the embryos are viable, having good genetic material, when you screen generally for any mutations, any nucleotide polymorphisms, any chromosomal abnormalities, random screening is termed as a pre-implantation genetic screening. The patient does not have a history of any particular genetic disorder, but the genetic makeup of that embryo is screened to see whether it carries any anomaly. So pre-implantation genetic diagnosis is carried out by taking a sample of from the embryo for the genetic analysis. So the risk of Down syndrome, the risk of various other chromosomal abnormalities is high, especially in aging women, or even if the man has aged. So, and several other factors also may contribute to increased chances of mutations and genetic abnormalities. So pre-implantation genetic diagnosis involves taking a sample, a biopsy sample from the embryo, and then it is subjected to various kinds of genetic tests. So day one, there is a polar body. Polar body always has half the chromosomes, which have been extruded during the meiotic division of the ovum. Day 2, day 3 has a 4-cell stage or an 8-cell stage. Day 5 is a blastocyst. So these 3 are very crucial days for taking the sample for genetic analysis. Day 1 and 2, day 3, and day 5. And the embryo quality is then checked even microscopically, where they see the nature of the cytoplasm, of the blastomeres, the movement of the blastomeres, and it's called morphokinetic analysis of the embryo. And that's the way the embryo technologist under the microscope can evaluate whether the quality of the embryo is good or not. Besides that, one of the blastomeres are taken and checked for genetic abnormalities. If abnormalities are not found, and it's a good healthy embryo microscopically, then it is transferred to the uterus. But affected embryos can therefore be screened out and not transferred, and this will eliminate the chances of having an in vitro implantation with a genetic abnormality. So the embryo is then checked to address any kind of abnormalities, particularly chromosomal or even related to the DNA. So pre-implantation genetic diagnosis is when we check for a definitive genetic condition because that patient already has a history of some particular genetic disorder. So we are checking to see whether that particular embryo carries the same mutation that runs in the family. Pre-implantation genetic screening is when the patient has no known history of any genetic disorder, but the embryos are screened for any chromosomal or DNA aberration. Aneuploidies, one extra, one less chromosome. The chromosome study is carried out, any abnormalities in the chromosomes, any change in the DNA sequence. So this helps to improve the IVF outcome because you're checking, you're screening that it's a good, genetically good quality embryo that's going to be implanted. And pre-implantation genetic screening is generally done in cases where there is no known history of any genetic disorder in the patient, but there is advanced reproductive age. Both are aging, male and female, or the patient has a previous history of failed IVF cycles or multiple pregnancy losses, abortions, etc. So in this case, before implanting the in vitro fertilized ovum, before implanting the embryo, it is genetically screened for any kind of change in the chromosomes or in the DNA. Whereas implantation genetic diagnosis is generally carried out using genetic technologies to find out whether this embryo carries a genetic disorder which runs in the family, for which the family already has a history. It could be a single gene disease, autosomal dominant or recessive, or it could be a translocation or any kind of genetic abnormality for which the patient already has a known history. So there is no need to strain your eyes to read all this. This is just to emphasize the large number of cases, the large number of genetic abnormalities that warrant pre-genomic diagnostic techniques before an embryo can be implanted. Molecular testing is necessary because there are so many chances of so many different kinds of mutations, different kinds of abnormalities, aberrations that could be affecting the embryo from further development, or that could result in an abnormal fetus and an abnormal offspring. So pre-implantation genetic diagnosis is carried out by collecting a sample from the embryo. So there are three main methods. The polar body biopsy method. So the polar body, which has a sample of the chromosomes from the embryo, the polar body is collected and genetically tested, not very often carried out. Blastomere biopsy. One blastomere is collected from the embryo, and collecting the blastomere does not affect the embryo at all. It repositions itself with the morphokinetic movements and divisions and again regains the loss. So one blastomere is collected and checked genetically, or more often the multiple cell biopsy or blastocyst biopsy is carried out, whereby cells from the outer layer, the trophectoderm of the blastocyst. It's called a blastocyst biopsy because the blastomeres are not touched, but cells from the trophectoderm, the outer layer, is collected for the genetic analysis. So for genetic analysis, for pre-implantation genetic diagnosis, either a polar body biopsy, a blastomere biopsy, or a blastocyst biopsy is carried out, and more often it is the blastomere or the blastocyst biopsy, which is carried out for the purpose of genetic analysis. So in order to check whether the embryo is of a good quality, whether the DNA is of a good quality, whether there is any genetic anomaly associated with the embryo before implantation, there are two main modalities. Newer non-invasive methods where we do not touch the embryo, and the invasive methods which have been established and which are very successful to determine the genetic anomalies of the embryo to be implanted. So this is the embryo. So the newer non-invasive methods could involve imaging through time-lapse photography to see the morphology of the blastomeres and the morphokinetic movements of the blastomeres, which an experienced embryo technology can recognize as a good quality embryo or not. And then blastocyst fluid sampling, where a fluid from the blastocyst is collected, and then the DNA from that fluid is isolated and checked for any anomalies. Or there is cell-free nucleic acid, which may be extruded into the culture medium. So the spent culture medium after the embryo is taken, and from day 3 to day 4 or day 4 to day 5, the culture medium is changed periodically. So that spent culture medium is taken and the DNA is isolated from that, and that may have nucleic acids which could be checked for any kind of abnormality associated with the embryo. So by taking the DNA from the fluid or from the media, we are not touching the embryo. So these are the newer non-invasive methods. They have not proven yet to be so successful, but I think more experience and time will make them into the methods of choice. More commonly used is the blastocyst biopsy, where the trophectoderm cell is taken, and then a large number of techniques are used, like SNP analysis, microarray technologies, next generation sequencing, etc., to determine any anomalies associated with the DNA that is isolated and collected. So day 1 and day 2, this is the time for the polar body. Day 3, day 4, the biopsy of a single cell, the blastomere is taken, and day 5, trophectoderm cells are taken for checking the DNA for the genetic analysis. So in the blastocyst biopsy, the entire procedure is the same. In vitro fertilization, the embryo is cultured, and at day 5, when the blastocyst reaches day 5, the blastomeres from the embryo are not touched. In a blastocyst biopsy, at day 5, only cells are taken from the trophectoderm. Cells are taken from the trophectoderm, and those are genetically analyzed. So that keeps the blastomeres intact. In the blastomere biopsy, one blastomere is collected for the genetic analysis. And in the polar body, less used method, the polar body is collected for the purpose of genetic analysis. And either polar body or blastomere or trophectoderm cells, all these may be subjected to any of the following techniques: multiplex qPCR, comparative genomic hybridization, next generation sequencing, FISH technology to check for chromosomal abnormalities. This will sequence the DNA and tell us about any aberrations in the DNA sequence. And the embryo, therefore, can be checked for its genetic quality before being implanted. Now it is validated that next generation sequencing is the technique of choice. It is highly accurate, it is sensitive, it can be done with just the sample collected from the media or from the trophectoderm, and therefore it will provide good information regarding the quality of the DNA. So pre-implantation genetic analysis tells us about whether the chromosomes are having any deformities, any abnormalities, or whether there is mutation in the genomic DNA of the developing embryo. And the first person to give us information about this was Handicide et al. In 1990. So the non-invasive techniques also are picking up. where the cell-free nucleic acids are collected from the spent culture medium, and they are also sequenced by molecular techniques. And successfully alpha thalassemia embryo was detected, and it was not implanted because there was a positive indication from the genetic analysis for the alpha thalassemia mutation. So it's a very, very good technique, and they find that this cell-free nucleic acids from the culture medium, if that is carried out, that proves to be more effective and more efficient even than taking a blastomia biopsy for genetic analysis. So probably there will be a shift in technology to use more of the cell-free nucleic acid material. Blastofluid sampling also is picking up, where the blastocyst fluid is collected, and then it is checked by qPCR or any of the other technologies, next generation sequencing, etc., for any anomalies. So PCR is carried out. It can tell us about single gene mutations in the nuclear DNA. It can also identify mutations associated with the mitochondria. FISH technology is also performed to tell us about aneuploidies or chromosomal abnormalities. So all in all, these techniques, the ACGH technique, microarray analysis, qPCR, karyomapping, next generation sequencing, all of them, all the molecular techniques have been used in different laboratories. They standardize different techniques along with the PGD to improve their diagnostic significance before the implantation of a embryo. Karyomapping, when next generation sequencing is used and the offspring's single nucleotide polymorphism is determined, the DNA abnormality is determined, a karyomap is prepared. And karyomap identifies not only the offsprings, but also it gives an idea of from where this abnormality is arising by checking even the parents' karyomaps. So karyomapping determines the mutation and is very, very effective for various small single nucleotide changes, which can therefore be understood that there is an abnormality associated with the embryo before implantation. So karyomapping is also carried out in addition to the other sequencing techniques. And karyomapping helps to prepare the map in order to identify the sequence of events that could lead to the transfer of this single nucleotide polymorphism. More recently, single cell genomics have been used. This offers higher resolution for the purpose of genetically screening and genetically diagnosing the embryo. The single cell genomics consists of two major steps. So you are identifying the DNA, any abnormalities in the DNA. You are isolating the DNA, amplifying it, and then checking for any sequence abnormality in the DNA. And this is all done through high throughput technology. So it's very fast and very accurate. Okay, so from the single cell, the entire analysis is carried out, which makes it very, very conducive for in vitro fertilization technologies. Now, in single cell genomics, clubbing the genomics along with transcriptomics, not only the DNA, but even the proteins and the products of DNA, the RNA, single cell RNA sequencing is also being carried out so that we can check not only if the DNA is normal, but if the DNA is functioning normally. If the DNA is being transcribed and the molecules produced like the RNA and the proteins, if they are also normal, that can be checked through single cell analysis. So single cell RNA sequencing, single cell transcriptomics has also helped to give more information regarding the quality, the genetic quality of the embryo, in telling us not only whether the DNA is normal, but whether the DNA function is also normal. And that has given a large amount of research data to tell us about the epigenetic controls in this little embryo at day 5. Now, while PGD and PGS have been carried out with great success in most of the laboratories in almost all the cities of our country. And now it becomes possible to say that now the quality of this embryo is very good. So now they don't need to implant 4 or 5 embryos in order to get success for the in vitro fertilization or the embryo transfer. A single embryo can be transferred. So that reduces so many side effects of twinning, side effects of quadruplets, etc. So this embryo selection, checking the embryo for morphokinetic movements under the microscope, as well as for its DNA quality, helps to eliminate the possibility of having to load more than one embryo. So a single cell embryo transfer is now possible. And this is made possible because of all these important techniques that have been used together to check the quality of the embryo. And the single cell embryo is very often implanted for a phenomenon known to the common man as savior sibling. This single embryo, which is now known to be of a good quality and does not have the aberration that runs in the family. It does not have the mutation for which the family has a history. So this single embryo is planted to serve as a sibling that could donate bone marrow or blood to an earlier affected sibling. Let us say that this family already has one child, and that child is 4 or 5 years old and carries a genetic disorder like thalassemia, alpha thalassemia, which is very critical, and beta thalassemia. And that child has to be carried every few months to the hospital for transfusions, sometimes for bone marrow transfusions, sometimes for blood transfusions. And the child has to be put through so many tests. It's very traumatic for the parents. The child suffers with so many side effects and dilemmas, etc. So it is traumatic to have one child with a genetic abnormality and to cope with all the medication needed for that one child. And most of all, it is very difficult to get matching bone marrow and matching blood when required for the transfusions. Now, this second embryo is implanted into the mother so that the child born can serve as a donor for the elder child. It can give bone marrow, which will have a very, very close match, or blood, which will be matched to the earlier sibling. So this embryo is implanted and developed mainly for the purpose of helping the elder affected child. So this sibling serves as a savior to help the child to get a matched organ, a matched bone marrow transplant, a matched blood. How good this is, how ethical this is, how moral this is being debated, but the idea and the kind of trauma and relief it provides to the parents has encouraged doctors to look into this very, very seriously. So single embryo transfer for the purpose of helping an older affected child to obtain matched tissues. When the embryos are checked and found to be of genetically good quality as well as morphologically of good quality, they can be frozen. They can be frozen so that in case in future the parents want to have another child, they already have a good quality checked frozen embryo. There are many methods for that purpose as well. Now, very often, besides the genomic DNA, the mother may have a mitochondrial DNA mutation. So this mitochondria comes to the embryo only from the mother. And if the mother carries a mutation, then 100% that embryo is going to be affected with the same mitochondrial mutation. So they have developed a technique of 3-parent babies where the nuclear material is taken from the mother, nuclear material from the father, but the affected mitochondria in the cytoplasm is removed. Only the nuclear material is taken. And the mitochondrial DNA, the mitochondria and the cytoplasm come from another donor, a donor female who does not carry the mitochondrial mutation. So the mother contributes her genetic material, the father contributes his genetic material, but the cytoplasm with the mitochondria come from a donor. So 3 parents are involved in making an embryo which is free from this mitochondrial mutation. So the female has a mutation in the DNA of the mitochondria, but her nuclear genome is normal. So this ovum is enucleated and the nucleus is taken out. Okay. A donor female provides an ovum where the cytoplasm has normal mitochondria and normal mitochondrial DNA. So the nucleus is enucleated and discarded, and the cytoplasm is used for the purpose of getting base for the formation of the pronuclei for the purpose of fertilization. So the fertilization is carried out, and the embryo is therefore a mixture of 3 different materials. This is termed as mitochondrial replacement therapy. It's a special form and modification and advancement over the routine in vitro fertilization. And it prevents the offspring from inheriting mitochondrial DNA mutations from the mother. If the mother carries a mutation, it can be removed and only the nuclear DNA can be transferred for the purpose of developing the embryo. So this was made legal in 2015. And regulations were introduced in 2016. And in 2016, there are many instances of very good viable embryos developing positive conception and positive implantation, normal fetus and normal child offspring with the help of pronuclear transfer or mitochondrial spindle transfer or the polar body transfer. And these 3 methods help to carry out the mitochondrial replacement transfer. So the mitochondrial replacement transfer by pronuclear transfer, after the fertilization, the male and female pronuclei are removed because this cytoplasm has mitochondria with a mutation. And those pronuclei are then introduced into a donor cytoplasm, where the donor ovum is removed, nuclei are removed, and the cytoplasm serves for the embryo. Pronuclear stage transfer or spindle transfer, when the chromosomes are attached to the spindle apparatus, the nuclear material is removed from the maternal cell, that is the ovum, and only that spindle is then transferred to the embryo. Spindle transfers also proved to be very, very successful. Not only the ovum has to be checked for its mitochondrial DNA and its nuclear DNA, but even the sperm genome should be checked, and it makes a very good procedure if the sperm quality, nuclear integrity, and DNA quality is checked before the sperm has to be used for the purpose of in vitro fertilization. So checking the embryo, yes, but before that, if we check the ovum and the sperm, it gives additional advantage. The problem is that there are millions of spermatozoa, and maybe even if a few are checked, it does not account for the one that could be the sperm selected for fertilization. That is why PGD and PGS are very necessary despite checking the gamete genomes. More recently, they have developed IVF on a chip using microfluidic technology. When you look at the whole technology of IVF, it is very, very laborious. It involves several steps by an expert andrologist, by an expert embryo technologist. We cannot replace the steps so that the gynecologist or the surgeon or the clinician involvement. We can't overlook that, but the laboratory steps can be automated. So we can automate most of the checking procedures, most of the preparative and culture procedures, and this will reduce the stress. By automating it, there is less human error, less human intervention, and that can reduce the stress exerted on the gametes and the embryos. It could also minimize operator to operator variability. From person to person, there could be errors introduced in the culture system, in the procedures. So that could be minimized if all the steps, laboratory steps, are automated. So sperm selection has also been automated using microfluidic technology. Here, an infogram to show that by microfluidic chip technology, you place the sample here, place the medium here, and this microfluidic system serves as a mini cell sorter. And the more motile, the more viable, and the morphologically normal fraction can be separated from the dead spermatozoa, from the bacteria in the sample or the epithelial cells in the sample, which could be separated and thrown out as waste. So this manually cannot be done. Manually, we can observe, manually, we can assess the sample. And by sperm preparation techniques, about 60% efficacy or 70% efficacy can be obtained in getting a good quality fraction of spermatozoa. But the microfluidic chip system has ensured that the flow cytometric movements can isolate very, very good quality spermatozoa in comparison. So sperm selection, oocyte denudation, positioning of the sperm, screening of the embryo, fertilization, embryo culture, media replacement, all this could be done by microfluidics, automated systems where there's controlled, regulated flow of the system of the culture medium, etc. So there's a droplet-based microfluidic system. There's a digital droplet-based microfluidic system. It controls the secretion, the sections of the fluid. You do not have problems of molecular diffusion or cross-contamination or extra pressure or faster movements of the molecules, etc. Everything is under control, speed, and controlled pressure. And this microfluidic system reduces the time. It makes the reaction time faster. It increases control over dispersion, helps mixing and separation in an automated manner without human intervention or interference or error. By monitoring the embryo, also they have introduced the automated system, and in a fully automated incubator fitted with time-lapse photography, the embryo secretions can be collected for checking genetic analysis. The oxygen consumption can be checked. The CO2 levels can be checked. And this fully automated incubator can help the embryo to grow in a very, very sterile environment and a very, very quality assured environment. So this is earlier, all this was carried out in the laboratory. Now all this can be carried out automated, and very little human error can affect the embryos or the gametes, etc. Robotic-based IVFs with complete automation are also being introduced, and this is in coupling with the microfluidic system. So precisely controlled fluidic gametes, embryo manipulation, providing complete sterile biomimetic environments for the culture, facilitating microscale genetic and molecular bioassays, and enabling miniaturization and automation could make the procedure faster, less problematic, and less contamination. Another entirely different contribution to in vitro fertilization is in vitro gametogenesis, where stem cells have been used to develop ovum or spermatozoa. Japanese scientists have been very successful in this, and they have developed human oogonia from the induced pluripotent stem cells so that it can replace the cell if not produced by the individual. CRISPR is a genome editing technique and has been introduced recently to remove errors, to do a repair mechanism. If there's an error in the DNA, remove the error and correct that error. Edit the DNA and replace it with the normal sequence so that you have an embryo with without a DNA mutation. This has been very successful in bacterial cells and in various experimental models. It has been tested in vitro in the human cells, but to date, laws and rules and regulations are not in place to have CRISPR-Cas edited um, embryos for the purpose of a routine laboratory. But there are reports, especially from China. Most of the reports have come in from China that they have used CRISPR-Cas methods and gene editing, and they have corrected a mutation responsible for hypertrophic cardiomyopathic anomalies, and they have made normal embryos despite the fact that the embryo carried a DNA mutation. So using CRISPR-Cas9 is not yet in place for the rest of the world, but China reports that they have used it with success. And it could be lead to the development of designer and custom-made individuals where you could do the editing and introduce genes of choice and have a designer embryo implanted for a designer baby. So IVF technology has greatly advanced and the advances are still continuing. Thank you all for a patient listening. Thank you to the organizers.